Center Praside, Mandana Hills, Hyderabad. I am the organizing secretary of AIOA 2023, which is being conducted at Hyderabad Plaza Hotel, Begumpet. Here, what is the main agenda of this AIOA conference? So what is this AIOA conference? Association of Indian Ophthalmic Anesthesiologists, which is a big association, budding anesthesia group from the anesthesia building, which provides care for the patients performing for the ophthalmic surgery. So for this conference, which is a 2-day-long conference, where we are doing it in Begumpet, and all over the states of India, around 100 delegates have come to attend this 2-day-long conference. Here, what we have done is we have exchanged many thoughts from the senior faculties and senior persons about the newer developments, the research papers, and what next to be done for the best better care of the ophthalmic patients. And we had a beautiful half-a-day workshop, mainly pertaining to the complications in ophthalmic anesthesia, challenges in ophthalmic anesthesia, how to give regional anesthesia, eye surgery blocks, and also crisis management. And then we had a privilege to give second annual oration to Professor P.M. Chandrasekhara, who is from the Retina Institute of Karnataka, Bangalore. He is a very senior anesthesiologist working for ophthalmological anesthesia for the past 40 years. We even had a oration, and now, last but not the least, we have even had an agenda to make comprehensive guidelines involving ophthalmic surgeons, anesthesiologists, cardiologists, and physicians to frame guidelines for ophthalmic anesthesia for the ophthalmic surgeries.
Association of Indian Ophthalmic Anesthesiologists Association. It was founded in the year June 2020, and we have some 110 members, not only ophthalmologists but all the healthcare workers, as Dr. Anil was mentioning. We have ophthalmologists, paramedics, and those
probing, or is LMA enough with a good seal of an LMA is enough, so that is still debatable. So may be used as a starter, especially in the absence of an IV axis or difficult IV axis. Sevoflurane is the most commonly used inhalation induction due to its poor airway irritation. It does not have a pungent odor, and both a smooth and relatively rapid induction and elimination. So, and we also give pre-op glycopyrrolate, which will reduce the anesthesia level if the procedure ends up prolonging. Now, advantage of endotracheal tube, it's actually the gold standard technique for probing and syringing, but it can cause mucosal trauma. The use of muscle relaxants that systemically have a longer duration of action than the tubes. It has safe airway control. It provides a lack of mechanical stimulation of the airway. Effective, so there is no gastric insulfation is not there. It avoids the risk of inhalation of fluids used for easy control of breathing level and duration of anesthesia in case the procedure gets prolonged. The emergence from anesthesia, the most critical phase in children. The inhalation induction by mask may be used as a starter, especially in the absence of an IV axis or difficult IV axis. Sevoflurane is the most commonly used inhalation induction due to its poor airway irritation. It does not have a pungent odor, and both a smooth and relatively rapid induction and elimination. So, and we also give pre-op glycopyrrolate, which will reduce the salivation significantly. Now, face mask. In our institute, we don't just hold a face mask because for us the positioning will hinder syringing and the irrigation maneuvers. It doesn't prevent or avoid vocal cord stimulation or cough triggered by the inhalation of the dye fluids that goes into the oropharynx. And I sit in one week prior to the procedure. Now, conclusion, again we have to weigh the pros and cons of ET tubes and LMA. The child should be thoroughly evaluated as there may be frequent surgeries later. Associated syndrome should be evaluated and appropriate treatment investigation should be done pre-op, and careful extubation with proper suctioning should be done to avoid aspiration. Thank you.
I have a question. You don't have any experience using the face mask for it's just probing.
Yes, probing, yes. Probing, if it's just a 1 or 2 minute.
You need to ask the surgeon that whether he's
Yeah. So sometimes they say they just want to probe and we start holding the mask and then they'll say we'll have to suction. Then we'll have to go in for.
And how do you hold the mask? You have to hold from the patient, not from the head end.
Not from the head end, so it's from the shoulder end.
That's a technique which is no hand.
Yeah.
You have to learn.
Yeah.
Also, it's very important question whether the surgeon is going to do bilateral or single eye. If it's a bilateral, usually we do it under the mask. But if it's a bilateral thing, surgeon, we have good coordination with the surgeon. He will always let us know that we can put in a lentil mask and we can put patient. No, one shoe fits